We're really here just to talk about whatever's of interest to you that's within our scope within the system. We thought we might just give a brief overview of kind of some of the specialties and to highlight a few things. And then, as you mentioned, Mark, be open for questions and dialogue wherever that makes sense.
Okay.
And as we understand it, maybe 10 to 15 minutes of kind of talking, then the rest for questions and answers. Does that still fit with your agenda for today?
Yes.
Okay, sounds good. Well, Josh whittled off some of the specialties that we oversee or engage with. We recognize how important this is to the community, recognizing people need care and we want them to get their care here locally. We want them to receive it. We want everyone to receive it in a high quality way. And healthcare is dynamic and it's under quite a bit of stress right now. But some of the programs that we work together on that we're particularly proud of and just want to share with you, one is our cardiovascular program. And we have a really nice environment here where all of the cardiologists in our community are in one team. We also have the cardiac surgeons, and they're located in the same location and again, part of one team. And inside of cardiology, we do almost the full spectrum of cardiac care, excluding things that have to be done at a quaternary care facility like Oregon Health and Sciences. But we do interventional cardiology, i.e. opening blood vessels. We do electrophysiology, which is dealing with rhythm disturbances of the heart. We have a relatively new structural heart program where we're replacing valves and doing other interventions within the heart through percutaneous or peripheral means rather than traditional open heart surgery. And we have a surgical program. And our surgeons are employed by Stanford University, and they're integrated and partnered with our team. So that's kind of a high level of our cardiac program. It's something that we're very, very proud of. And one of the things that's important to us that we're working on is right now, when patients present with an acute cardiac condition, sometimes we don't have enough beds available to take care of them here at Good Samaritan or in Corvallis. And we really would like to be able to take care of all the patients that we can. We've got the expertise, we've got the talent, we've got the support, and this is a program that's really important to us and recognize how important it is to the community. And we can take some questions that I might turn over to Josh maybe to talk a little bit about one of our other specialties, and we'll kind of go back and forth. Yeah, if you want to hit GI.
Yeah, so GI, gastroenterology, is new to Samaritan. I think folks, if you've lived in this area for a while, you've known Mid-Valley GI or potentially a couple of clinicians that work at the Corvallis Clinic that do GI work as well. If you've had a colonoscopy in this town in the last, 10 years, there's a good chance one of our formerly Mid-Valley GI docs did that work for you. And so over the last year or so, we've been in conversations with them about their need to partner with someone larger for some economies of scale. They were struggling financially as an entity and trying to figure out how to recruit and make ends meet. We are thrilled that they have joined us. So Mid-Valley GI is no longer and is now Samaritan Gastroenterology.
Wow.
They're officially part of Samaritan as of April 1st. So just 2.5 months, coming up on 3 months ago. So extremely excited to have those folks on board. I will tell you, for gastroenterology in our community, it is an area where we have more demand than we know what to do with. And so we are actively growing that team. We actually signed a new doc. They won't start until they finish their fellowship next year. We signed a new doc Thursday of last week. We're looking to grow the PA team as well. So we have a team of 4 APCs, formerly known as PAs. You might know them. So APCs is kind of what we call them now. That see most of the clinic patients. So they deal with a lot of the inpatient or the stuff that happens inside the walls of the clinic. Our physicians are mainly covering the hospital, covering the endoscopy center, doing acute care procedures, those kind of things. That's more where they spend the majority of their time. They do have time in clinic, but it is limited because they are trying to cover the 3 Valley hospitals and also work in the endoscopy center, which is a jointly owned operation that we have with those clinicians. So we're continuing to expand that team. I think, our target number, well, I'm not sure exactly what it is. We sit at 3 physicians right now and 4 APCs. I think our goal is to get it up to probably closer to 7 physicians in there. And we're We actually have an offer out today to an additional APC for that group, so we're looking to grow that group. So it's an area we're investing a lot in right now. I think it's a really important service line for our community. I think the wait times have been longer than we want them to be. Hard to get people in, so really just trying to expand access for that service line in particular. So yeah, very excited to have those guys on board and part of the team, and looking to continue to grow and invest in that one. So anything I should have mentioned on GI?
And I'll just mention that this is a theme, it wasn't really Samaritan's plan to get into gastroenterology, but there was a need in the community. In fact, not long ago, there were 7 or 8 gastroenterologists in our community, and a couple have left the community. And so this is an instance where Samaritan really needed to step in an effort to secure this service for the community so that people could get the care that they need. And where we met Mark, of course, was talking about concerns that we have about the fact that not all of the gastroenterologists in our community are still working at the hospital. So some have chosen to work just outside of the hospital. And of course, if any one of us or anybody that we cared about came in the hospital with an acute need of a gastroenterologist, and some of those conditions are life-threatening, that's important for us to have. So this is an example of where Samaritan's had to step in and kind of secure a service, and we're together trying to build that up to where it will meet all of the needs of the community.
So it's kind of you not to name names.
We all know who you're talking about.
But at the Oregon, I hope you don't mind my jumping in with a question.
Sure.
But at the Oregon Health Policy Board meeting, one of your GI people made it very clear that he felt abandoned by the Corvallis Clinic, that your folks were left to do it all, whereas there had been a partnership.
Yes.
And is that a theme that's going on in the community or not?
Is it a theme outside of GI? Is that the question?
It's definitely a risk. In multiple clinical areas.
I would say within medical specialty specifically, it is the instance that we are impacted by with the medical specialties. I think to Jeff's point, it is a potential concern in other areas as well.
Okay.
What I would say as well, we talk about Samaritan kind of stepping in to try to secure the service line. Part of what you're referencing, Mark, when we have people step out of the call pool, which is what occurred and what was talked about in the last meeting we're at, is that it spreads our 3 remaining doctors very thin. And they can't cover a call for all 3 hospitals, run the clinic, run the endoscopy, so they just can't. And so, as part of that, Samaritan has invested substantial funds to try to prop that up with locums. I assume people are familiar with locums, but if you're not, it's essentially docs that we hire that are not permanent employees. They come in, they work shifts, they take over things for a period of time, kind of come and go. Some traveling nurses is kind of an example of that type of environment as well. They're very convenient. It's nice to have those folks available to us. They're also very expensive and multiples of expense over what we would pay if we had someone ourselves. And so, our goal is to grow our own team so that we're less dependent on that, so that we're less dependent on any other entity for that matter to be able to provide the service. And so that's our mission in that, is to grow our own team where we don't have to rely on them as much.
Thank you. Sorry to interrupt.
No,
I'm getting some feedback that people are not hearing as well. Some are, some are not. So just amp your voices up if you can.
we will talk louder. Thank you, Mike.
If it helps for us to talk louder, we definitely can raise our voices. Apologies to anybody that's sitting close to us. We thought we might talk just a little bit about cancer. And then I think I can speak to that, and then Josh is going to highlight some of our other
We can lean
specialties.
into Mike.
And then maybe we can talk a little bit about some of the gaps that we know exist in our community right now. So as Mike knows from his career, we have a very important radiation oncology team that takes care of patients with cancer that require radiation. And that team's healthy and strong, and we're having some transitions, but recruiting, we have a new doc that joined that team this year, and we'll be looking to add another one in the near future. The medical oncology, those are the doctors that prescribe and administer chemotherapy, as an example, or some of the newer therapies that different from the traditional chemotherapy, immunotherapy, those sorts of things. We have a really fantastic team of medical oncology doctors. And that program's gone through some challenges over the course of the last 4 or 5 years, where I think all of the previous medical oncologists left. And so some of them are still in the community, and Samaritan has brought in some more oncologists to fortify the team that supports the cancer services throughout the region and through the Samaritan system, through the Pastega Cancer Institute, et cetera. And so that's a team that's been building and growing and is really fantastic team. And they're servicing the Tri-County area, visiting patients on the coast as well as Eastern Lynn County, in addition to Corvallis. And we have a strong cancer team there. And then Josh, you want to give a highlight of some of the others?
Yeah, sure.
And then we can talk about some gaps maybe, if that makes sense.
Yeah.
Yeah, I can speak to rheumatology as well. So rheumatology, we have 3 docs that work in our rheumatology clinic. It's another specialty where we have more volume than we have clinicians to manage. And so that practice as of right now is currently closed to new patients. We are very actively recruiting for an additional rheumatologist. We're looking to expand that team. We have been for 6 to 8 months at this point, looking to add another rheumatologist to that team. We have a backlog of rheumatology patients. It's always our goal for folks to be able to stay in our community and be seen by folks in our community. So it is our goal to grow that team. Right now, we are, like I said, actively recruiting, but the rheumatology practice is closed to new patients just because of the panel sizes that our clinicians are already seeing. And part of what you may imagine with that is when a panel size gets to a certain level, it's very hard to get folks back in for follow-ups. And so you can see new patients, but then when your schedule's booked out for 6 months and you need to see that same patient back in 2 months, 3 months, there's no slots in the schedule. And so in some ways you have to manage that panel size to make sure that you can still do follow-on care for the new patients you take in. And so, we keep a very close eye on that. We manage the schedules very tightly and closely to make sure that we're getting patients in when we can. But right now, rheumatology is a space where we're struggling to have enough clinicians to be able to deal with the patient volume that we have.
Wow.
So.
And then maybe just briefly to speak about gaps that we're aware of. We're very well aware that there's a gap in terms of neurology coverage here in the region. So it's very hard to get in to see a neurologist. And so we don't have neurology currently in our practice. It's something that we desire to build. That will take time and effort, planning, and resources. And so that's something that Josh and I are interested in doing as soon as we're able to do that, because access to neurology care is very, very limited here. So that's just an example of one area that I think is struggling, and we see the potential for our team to fill a role if we can get all the pieces to come together on that. So there's
getting the people is what you need.
Yeah, well, it's essentially building a new line of business with everything. There's a whole lot that goes behind kind of putting something like that together, and recruiting and building the people is a really important part of that. There's a lot of behind the scenes work to get something like that going too. So, but that's an area that we recognize is a real need in our community. And there's some other emerging needs or areas that are at risk. Neurology is the one that kind of pops to the top of the list for us, but we'd love to hear from you guys. Any concerns that you have, or engage in any conversation about any part of this?
Yeah.
Josh, anything additional to add?
I don't think so. I think those are the key ones we wanted to touch on. Obviously, we do have some additional specialties within the division. If you got questions about those, happy to answer those. But I think those are the key points we want to talk about today.
Yeah.
Okay. I think I've sort of asked my question, which is just the pressure of the Corvallis Clinic downsizing some areas and not seeing certain kinds of patients. What does that do to you financially, and what does that do to you medically? And you've sort of answered the medical side already.
Yeah, I mean, I can speak to the financial side a little bit, and this goes back to the locums conversation, really, right? Is part of people available.
Can't hear.
Goes up in the hospital, in the middle of the night with a GI bleed of some kind, right? And so what that means is when we have less doctors to cover that service, that we employ locums to help out, right? To come in and cover some of those gaps and to give our docs a little bit of breathing room and not have to be on call 24/7, 365, which is, as you might imagine, GI is a heavy call group, right? It isn't hey, I sleep 5 nights out of 6 and nobody calls me. It's most nights I'm going in to do something. And so it's a heavy burden for those guys. And we talk about financials, the fact that we're employing locums to fill that space, it's a financial burden. It is. It's expensive. It's an investment we're willing to make to take care of the community and keep that service line, viable. But it comes at a pretty hefty expense for those resources to come in and cover that. And there's typically, call coverage and things that they aren't free, but when we compare them to locums cost, it's significantly more for us to hire locums to fill that space.
Yeah, that's very interesting. Thank you. There was a hand over here. Linda.
Yeah, I was just wondering if and I don't know enough about it to know if
Speak loudly.
Oh, don't know enough about it to know if this is a good question or not, but is the school in Lebanon, is that helping feed specialties at all, or is that more general practice?
Good question.
It
You wanna
is.
take that one, Jeff?
Yeah, I
Yeah.
can start then. The osteopathic school in Lebanon has trained a lot of physicians, many of which are still in our community. So it has met some of the need here, and that's been fantastic. So there's a bit of a pipeline there. A lot of those folks end up going into primary care specialties, but some go into highly specialized fields. So as an example, in our cardiology practice here, our cardiologists help to train cardiac specialists here. So we have a cardiac residency program here. And so we have the opportunity to train people, and our lead cardiologist is every year looking to see who he thinks would be a good fit for the team long term and considering adding them to the team. And that we have experienced that here. And it's so it does impact some specialties as well as primary care or general care.
Okay. Let's see, Fritz, do you have?
Yeah, Mark,
any-
we do have some questions online. First, Kathy, you had posted a question. Go ahead and come off mute, ask your question, and then Bobby, you're next.
Okay.
I was just wondering, I actually have 3 questions, but what's the biggest driver or maybe obstacle that's getting in the way of recruiting more specialists to Corvallis?
Good question.
There's a few things that play. Do you want to take a swing at that, or do you want me to?
You go first. Yeah, I'll chime in if needed, but yeah.
It's very different from one specialty to the next. And Corvallis is a beautiful, wonderful place, and I can't see why everybody would just want to come here, because I love it here. What I will say is that the burden of being on call is a factor that comes up frequently. Sometimes people will find that if they go to an urban area, they may only have to take call a couple of times a month if they're in a big practice. And being on call is burdensome. You've got to be available to come into the hospital, and it disrupts sleep typically. And so it's a big factor in doctors' lives. So a lot of people are attracted to go to urban areas where they can have a reduced call frequency. You may come to Corvallis, and for an example, if any, I'll use myself as an example, none of you, if I were to have a heart attack tonight, I would hopefully make it to the hospital, and one of our cardiac interventionalists would hopefully go in and open up one of my blood vessels tonight. Wouldn't matter if it happened 5 minutes from now or if it happened at 2 o'clock in the morning. We'd have somebody there to do that work. Well, we have 3 of them, which means that they are on call 1/3 of their lives. So we cover 365 days a year.
Yeah.
And so that means every 3rd night, you're available, you didn't drink that glass of wine, you're there to answer the call and rush to the hospital in a moment's notice to take care of that.
Wow.
If you were to go to Portland, a lot of those practices are taking call 1 in 8 or something like that. So that's one of the challenges. We have a very highly specialized medical community where we provide excellent care, but we're small.
Yeah.
compared to a lot of other places. And so we don't have the economies of scale
Right.
of being able to have a large team. So that's
Yeah.
one of the potential barriers.
Yeah, and that's the business side of it, right? So an interventional cardiologist is not an inexpensive resource for Samaritan to employ, right? And so while we would love to say, let's hire 8 of them so that the call burden is right, we don't have a population that we're serving that requires 8 other than the call burden portion of it. And so to Jeff's point, it is a deterrent for folks who say, if I went to Portland, they've got a large enough volume of patients that justifies 8 interventional cardiologists. Therefore, my share is 1/8. Here, we have enough work, quite honestly, in interventional cardiology, patient-wise, probably for 2, but it's an unreasonable call burden. And so we do extend it out to 3, and we're actually recruiting for a 4th right now so that the call burden is reasonable, and then looking for other ways to utilize those resources so that it isn't solely just resources for the sake of call, which is a very expensive resource.
Yeah, boy, all the things the rest of us would never.
I think you
Go ahead, Kathy.
I think you pretty much answered my next question, which I was wondering what your number one goal is, say, in the next year. And that's probably it, I'm guessing, is to fill in those gaps.
It is, Kathy. It is to fill in the
Is that
gaps.
fair
and
to say?
Yeah, I think that's fair to say is filling gaps that we have where we know we need additional folks to cover and do it in as fiscally responsible way as we can. Because I think everybody understands that healthcare is a business as well as it is healthcare, and that it has to be financially viable for us to keep the doors open. And so it's finding that right balance with resources. Say, yes, we need to add a 4th interventionalist. How do we find things for those folks to do that also help offset the expense of them there while trying to manage, work-life balance and not a call burden that's 1 every 2 or 1 every 3 if we can avoid it. Yeah.
Thanks very much.
Okay, thanks. Bobby, go right ahead, please.
Hi. I have a younger brother. I'm now 86. He's 10 years younger. And he was born with a heart defect. He had a valve that didn't function well. And he's still alive. He's very active. The first replacement he had to go, gosh, I don't know how far. He grew up in Fort Wayne, Indiana, which is a fairly large community. Now, it hasn't always been so large. It was maybe 100,000 people when I lived there. I visited a couple of years ago. It was 300,000 or so. But so the first operation he had to go, oh gosh, I don't know which community he went to. He's had 4 or 5 of them. And the most recent one he had in his home hospital. He was only in the hospital during the day. He had the replacement of the valve. It went well. And so I was commenting on how technology has really come into it in a big way in that particular field, and I'm sure in many of the other fields that you deal with. Well, I was there 2 years ago, and I had
a stroke.
I had a stroke. Yes. I was going to say 6 days. It was going to be over his birthday. It was going to be a nice visit. But I ended up staying almost a month. Mm-hmm. And he and his wife knew the hospital system so well. As soon as it happened, I think I was in care within 20 minutes at least or less. Yeah. And I got excellent care after that, and they knew how to do it. And it was, but I knew that they had been through all these experiences because they were always traveling far away from home and making arrangements to have this heart defect corrected. And I'm sure that you have benefited probably in your heart program and many of your other programs by the new technology that allows people to really see what's going on right at that moment and not have to see it on an X-ray 2 weeks before and then act on it. But I just wanted you to comment on technology and how it has changed practices like that.
Yeah. For certain.
Thanks first of all, thank you for sharing your story with us. That sounds very scary, and then it sounds very fortunate that you got good care, and it sounds like in a timely manner. That's a perfect example of something that needs care as soon as possible, and so it's really important to have in our community. Technology is amazing, and our cardiac program is now replacing heart valves with patients that are sometimes sent home the same day, something that 10 or 15 years ago was unthinkable. And really the pandemic accelerated this process of discharging people the same day because there weren't beds available. But we do some of those with advanced technology. That's a fantastic example. I mentioned cancer care a few minutes ago. Some of you may have heard of immunotherapy, which is a way to boost your own body's immune system to attack your cancer. And although that's not a gadget that's inserted or that you wear, it's the result of amazing technology and development over a number of years that's providing more effective cancer care in a safer way, and extending lives dramatically, quite honestly. So technology is amazing, and it's also showing up in ways to support people that provide care. Do you want to take that?
Yeah, sure. Yeah, no, I was thinking about the same thing. I think we're going the same spot. I don't know if any of you have been in with probably most likely one of our primary care docs sometime in the last 6 months. I don't know if anybody's had that experience or not. You have. So, Mike, when you were in with your primary care doc, did they use something called a Bridge or DAX Copilot? It's an ambient AI listening software that we're rolling out. Was that part of your visit at all? Do you recall?
She was busily typing, so I doubt it.
Then probably not. No. So part of what we're rolling out to support our clinicians is they call it ambient AI listening, essentially. And there's a company that we're partnering with called The Bridge. And essentially what it allows to happen is us to have a conversation here as a patient and a clinician in the exam room. And it's creating my note for me in the background. So it's listening, it's pulling pertinent pieces of information, it's putting into the note. And so it really enables our clinicians. And to your point, Mike, she was typing away. She probably wasn't looking at you when she was typing, right?
She's very good though.
Yeah, no. And we have fantastic clinicians, and some are very skilled at charting in the room and still having that good interaction with the patient. But this is really intended to create efficiencies for our clinicians, that they're not having to do that as much in the room, that they're not going back to their office or staying late at night or coming in early in the morning to finish up charting, but that we're putting tools in place within the exam room to really help them so that they can have that interaction with the patient and the charting is still happening at the same time. And so obviously they've got to read through it, they've got to edit it, they got to make sure it's all correct. We don't just, sign things off blindly. But yeah, it's another space where technology is really helping with efficiency in healthcare, particularly when we're trying to increase volume and get more patient access and get more patients through the door. And anything we can do to help offset the burden for our clinicians of seeing patients in that way is stuff we're investing in. So
Right.
So I had a question.
Yeah.
Does that coordinate with my chart?
It does. So Karen, it's actually the Abridged software so we run our electronic medical record is Epic, and my chart is
Standard.
Yep. Epic is fairly standard anymore. This software interfaces with that. So it's creating the note in Epic for the clinician while they're in the room.
Okay.
And so, yes, it would be the same thing. So if you can see your doctor's note through my chart today, it wouldn't be any different for you. It's just they had some assistance in creating that note based on the conversation they had with you.
Cool.
Yeah, it's pretty slick.
All right.
Great question. Thank
There
you
are
very
more
much.
questions on.
Yeah.
Yeah, we do have some more questions online. Should I go ahead, Mark?
Yes. Alex, I
Okay.
think. Yeah, go ahead.
Yep, Alex is next, and then we've got Norma and Judy.
Okay.
So Alex, go for it.
Yeah, thanks. Thank you both for being here. So let's see. I have a question, but I have a really simple question. First, you mentioned locum. Can you define what a locum is?
Yeah.
With that.
Yeah, I assume it's a Latin term, but you correct me if I'm wrong. Locums. I'm not
Probably.
positive. Essentially,
It stands for locum. It's the first part of locum tenens.
yeah.
So it's basically an itinerant physician or PA who typically doesn't live in our community, who we hire to come into our community to fill in. So it's an itinerant clinician that comes in temporarily.
So Alex, in the instance of GI, so our gastroenterology practice, we have a pool of, I think, 6 locums that we use for GI, and they come in. Most of them come for a week at a time. They'll come in, they'll spend a week specifically focused on our acute care. So they'll manage Good Sam and Lebanon and Albany and the acute cases that come in there. And then they'll hand it off to the next locums. They'll hand it off to one of our GI docs. But yeah, that's how we're using them today in GI.
Okay, which I assume, yeah, is it kind of a premium as far as cost over staff?
Very much so. Yes.
Like a 200% or 150%, or is there any?
It's over 200%.
250,
300%.
Wow.
in that ballpark.
It's very expensive.
Yeah.
Okay. Well,
Yeah.
my question now, it might be more for a CFO or the new CEO, but I'm going to ask it anyway. So I just recently had back surgery with brain and spine, and they did a fantastic job. I really love Dr. Kim was my doctor. But speaking of finances, I'm kind of worried. I'm probably not the only one worried about Samaritan staying solvent. I certainly don't want to see Optum take over Samaritan. And so my surgery, I'm on Medicare, and my surgery, Samaritan billed $26,000, and Medicare paid $6,000. And I was thinking, and I noticed somebody posted online, what percent of your revenue is Medicare and Medicaid? I mean, I know Medicare and Medicaid pays substantially less than commercial insurance.
True.
I'm just wondering, I know you guys can't do anything for CMS to change reimbursement rates, but I'm just kind of worried when I see something like that, where that, that seems an unreasonably small amount to be reimbursed for what they did. So
Alex, you are on to one of the key issues in healthcare right now, in that labor cost is doing this while reimbursement is doing this. And somewhere in the ballpark for Samaritan about 2 years ago, those lines crossed to the point that the cost of doing business became more than what we got reimbursed. And so anytime we see lesser reimbursement rates, whether it's from commercial or government payers, it impacts our bottom line because our labor expense doesn't go down in tandem with that. It continues to go up. And so to your question about, we typically refer to as what's our payer mix, as in of the patients we see, what percent are commercially insured, which percent are government insured. Samaritan's payer mix is about 70% government insured. So split between Medicare and Medicaid. I don't remember the exact breakdown between the two. I think they're close to 50-50 in that space.
In fact, it's a little higher.
Is it higher than that now?
It's above 75% now.
Yeah.
So the commercial, what's left is mostly commercial insurance. And that in Samaritan is in the 23 to 25% range. So it's about 3 out of every 4 patients is either Medicare or Medicaid right now. And the old paradigm, the way that healthcare has worked for so many years is reimbursement from commercial insurance is high enough to subsidize the reimbursement that's government paid. Those are the economics of healthcare. It's been that way in our country for a long, long time. Well, it's starting to tip sideways for a variety of reasons. One is there's more and more Medicare and Medicaid and less commercial. So the commercial carrying the day is not happening anymore. So that's reality. Yeah. And I don't know if you guys are aware of this, but 50% of the health systems in Oregon are operating in the negative. And so that's a manifestation of the dynamics of healthcare that are not sustainable. And it's the environment we're living in right now.
Yeah.
That's why this group exists. That's why this group exists.
Yeah.
Good.
Yeah.
That's what we're fighting for, is some entirely new system.
Yeah.
Fritz, you have other online questions though?
Yeah, Norma, why don't you go ahead and come off mute? I know you would pose 2 questions. One of them got answered, but the other one hasn't.
Yes, I was very interested in what the revenue stream was regarding government reimbursement. And and concern about rural hospitals not being able to survive. And we do have some of those in the system. You've addressed that a bit. You did mention earlier when you were talking about cardiac, some of the services that Samaritan provides, and that you mentioned that you had good support there. But then you also talked about not having beds for people. And I do believe that there is still at least one floor, if not more, that were initially built for occupancy, but are storage. It's not an actual nursing unit. So I wondered about that. I mean, is there a need to open more beds? Are you having people staying 24 hours in emergency room or in a hallway somewhere? Or, large urban hospitals have dealt with that for several years. I didn't know if Samaritan was facing that. And then my second question was, you're having a lot of difficulty filling physician staff. What about nursing staff? Is that a problem as well?
Thank you.
Yeah. Well, healthcare workforces are largely under strain. So, in many places, there's a difference between the absolute number of beds and the number of beds that are staffed by nurses and others. So that's a dynamic here, just like everywhere else. I'll just call that out. And sounds like you guys have some interest in kind of the capacity issue, which is outside of our scope. But I will tell you on my acute care side, we're really trying to make sure that we take efforts to make sure patients are distributed as appropriately as possible, because we do have a limited number of, and I'll call them staffed beds, at this point in time. And so what this may mean for the future is that there are certain patients that need to come to Corvallis to get their care because they need specialty care that's only available in Corvallis. There are other patients that may be able to get just as good a care in Albany or Lebanon, as an example, if they don't need the specialist. We're starting to think about how do we distribute patients so that we can optimize our beds across the system. So that's a reality that we're going to have to look at and to try to solve for.
Yeah.
Great.
And the nurses.
And nurses,
We do have one more online. Judy, you want to go ahead and take yourself off mute? And
we can take
Answer
Norma's
first?
question. Yeah, I don't know we have a perfect answer, but we can.
They wanted to answer a little more of Norma's question.
Oh, go for it.
Yeah, so Norma, you had the question about nurses, and I will tell you, Jeff and I, as we represent this division, is really outpatient clinics, and we do have nurses in our clinics in certain roles. We staff a lot of our back office with a combination of nurses and certified medical assistants, and so that's kind of the outpatient realm. I don't think Jeff and I are the best ones to speak to the nursing staffing in the hospital, only because it's outside of our division. But to Jeff's point, we struggle across almost every single sector of healthcare employees, finding staff, finding the quantity of staff we need, retaining staff. And it's not always about salary. There's all sorts of factors that weigh into why people come and they go. But yeah, I think it's a problem across the nation. And Norma, part of what is driving, honestly, the labor expense to go up for everyone, because we're all competing over a scarcity of resource, and that resource is qualified healthcare workers, whether it's nurses or doctors or medical assistants. And so we get in this situation where we're competing for that. And the way you work to attract those is we keep increasing our labor cost to say, all right, they'll pay you 23 an hour. If we pay you 24, will you come work for us? Right? Because we need the resource too. And so some of those things drive the labor costs up because we have a scarcity of resource, and it's not unique to nurses. It's kind of across the board with healthcare workers. Does that help answer your question, Norma? Okay.
All right. Who's next up there?
Judy.
Whoops. So in the past, and now it's getting to be the ancient past. All the GI docs shared call regardless of what practice they were in. So it was Mid-Valley, it was the Corvallis Clinic, and it was a couple docs in private practice. So I was just wondering, you were talking about your GI docs being really stretched because there's only 3 of them. Have you considered sharing call with other practices outside Samaritan?
Yes, and that is the model as you referenced. That's the model that worked here for many, many years. But it was not our choice. Some of the doctors chose to relinquish their privileges to work in the hospital. We want them to work in the hospital, but some have chosen not to. So if they're not able to work in the hospital, they can no longer be in a call arrangement with us. And that's their choice. So yeah, you're exactly right.
How
It
can
would
they
end
treat
up-
patients but how can they treat patients but not have hospital privileges?
It's a really good question. I wish I could answer that. I wish I could answer that because we honestly believe that if you're gonna if you are a certain kind of doctor, you really need to have hospital privileges to take care of your patients. And you guys are aware probably that most primary care doctors no longer go to the hospital. When I started my career, we all went to the hospital every morning to do our rounds, went back at the end of the day and got up at midnight if our patient was sick. But most primary care doctors work only outside of the hospital now. So that's evolved over a number of years. Now, some of the specialists are starting to migrate in that direction out of choice. Again, there are some, it's a privilege to take care of sick patients in a hospital, but a lot of people feel it as a burden also. And so some people have chosen not to do that. We would love to have every gastroenterologist in town hold privileges at the hospital and to share call. We would love that.
Yeah.
But it's not, the
I get
reality
it
is
about the primary care, the internists and family practice people, but with the specialists, that doesn't make any sense to me at all that they would even be allowed to put people in the hospital.
Yeah.
agreed.
You're getting some head nods.
Yeah.
Yeah, Judy, I think that was our concern as well, is that, we had GI docs in the community that were doing procedures that may lead to complications, and then they would have no means to take care of those patients when they had complications occur.
And you have no legal recourse or anything. I mean, I'm so outraged.
Yeah, this is something in my opinion, for our state to handle. There used to be a federal hook that would keep doctors to maintain their hospital privileges. That went away about 3.5 years ago. And so there's no longer a hook that requires certain doctors to maintain their hospital privileges. And there's an opportunity for, in my opinion, and this is just me speaking, and I'm not speaking on behalf of Samaritan, but there's an opportunity for our state to do something about this. And that's something that we've brought to their attention.
Good.
But the wheels turn very slow, if they turn at all.
Yes, we know.
If they turn at all on this kind of a
There are a
topic.
couple of folks up here
So
tonight.
do you have a similar problem amongst all of the specialties, that there are certain practitioners who don't have hospital privileges and don't take call?
It's different from one specialty to the next. This came to a head with related to gastroenterology because it was, live and fresh.
Yeah.
On December 31st, we had a group of, I think it was six gastroenterologists. On January 1st, it dropped down to 4 and it's now 3.
Yep.
Okay, so this happened dramatically just 6 months ago.
Yeah.
But so GI or gastroenterology is quite honestly a very acute example of that challenge. And urology, I think it's not in our division, but I think is there still a urologist in town
I don't
that
know.
does participate?
I don't know.
But you're right, that's an area of risk. I
Yeah.
think there's one. I think you might be right about that.
To your point, Jeff, about, family practice docs, even you, in early days of your career, would go around at the hospital. That stopped happening because the concept of hospitalists came into light. And so they care for those patients and it became not their duty. The problem we have here in specialty is hospitalists aren't qualified to take on the specialty care patients, right? So it isn't like there's someone there to backfill that like there was for family practice and internal medicine. This is we need a GI doc and we don't have a GI doc. So.
Yeah. Yeah, it's a very different situation.
Yeah.
I think I saw a couple folks from
That's
our
it for our
legislative-
questions online. Thank you.
Okay, just a sec. I think I saw a couple people from our legislative committee taking a little note about that law needs to get put in place statewide, perhaps the law that went away federally. And we do have a couple of legislators locally who are pretty responsive around healthcare, Sarah Finger McDonald and Sarah Gelser. So, okay, go ahead, Fritz.
There we go. Alex did have his hand up again. I know we're probably running short on time because we have some business stuff to get to. So, Alex, if you want to go ahead and ask your question quickly.
Oh, thanks. Just quick question. The Samaritan purchase of state and hospital was withdrawn or stopped. And I know there was, there's financials involved. I don't expect you guys to really be behind. I know they were losing money and you guys have been losing money. But I'm just wondering, from your perspective, would that have been a good or a bad deal as far as your clinical services? Would that have helped or hindered if you'd have taken over that hospital and that practice?
Yeah, Alex, I will say from the medical specialties division, it's a little hard to say. There was only 2 specialties that Staten had that overlapped with us, and sleep medicine was one of them, which would have likely ended up in our division, but isn't something that Jeff and I own today. Samaritan does have some sleep medicine, but it isn't part of our division. And then the other one was cardiology. So they have an individual cardiologist and an APC up there in Staten that would have become part of our cardiology team had that gone through. I don't know how much of an impact that would have had one way or the other, to be honest. In our division, I'm not sure. It wasn't like there was a whole nother cardiology group the size of what we have that we would be merging together. And so 1 or 2 individuals joining the group in a somewhat satellite location. I'm not quite sure. We didn't get far enough into the analysis about how that integration would really work before, it was decided that it wasn't going to go through. So little hard to answer that definitively, but not a ton of overlap between what we have in our medical specialties division and what Staten had as far as specialties as well.
Okay. So folks, we do have some other business tonight. I think we'll wrap up the questions here. Mike had a comment and then you may want to respond to that, but go ahead, Mike.
2 things. One is I went to a fundraiser for the Samaritan Foundation 2 weeks ago, and they outlined the expansion into some of those storage the spaces that Norma talked about.
Yeah.
Yeah. So that, and in fact, I think I saw you there. So that's a little hopeful, isn't it? I don't know how long this is going to take.
I'm not involved in, we're talking about, I think, 4 North, I think the tower on 4. Yeah, that's been built for a number of years, but not expanded into. Hospitals outside of my division. I don't have a good answer for you on that one, Mike, unfortunately.
A little hope there.
Yeah. I would say, Samaritan overall is looking at the balance of how do we grow responsibly into spaces that will help keep us, financially afloat and serve the community well. And how do we, manage our finances all at the same time?
Yeah.
So it's a tricky balance, but there are certainly some areas, and we've talked about them tonight, where we do intend to grow and expand services because there's a high demand for it and it's what the community needs. And it's an area where we can make the numbers work enough to do it.
Last comment is, there's a comment, because I know you probably can't respond, is that one solution that's being considered seriously is creating a hospital district or expanding the one we have now to cover the three county area. just to stave off the Humanas and the Optums from trying to take our hospital. And I hope the community realizes that we're in that kind of a situation. We may need to raise the bonds and do the work to create a hospital district to help our hospital and keep it our own rather than somebody in Minnesota or.
Yes. Okay, thank you.
Okay.
Thank you both so much. This.
Yeah.
Thank you.
Pleasure to be here.
Yeah, thank you guys.
Thanks, guys.
Very enlightening and some things none of us would have a way to know.
Yeah.
Happy to share, happy to come back
Yeah,
anytime.
and
Yeah.
thank you for your interest and thank you for what you guys are doing on behalf of the community to make sure that we have adequate healthcare here.
Yes,
It's a challenge and it's a puzzle.
Yeah.
definitely. And it's a wonderful thing to work on.
Yep. It's a
Nothing more-
worthy endeavor.
Yes, nothing more important. So thank you very much. And
Thank you.
Thank you
we
guys.
may
Thank
call
you.
upon you again.
Okay, take care.
Nice to meet y'all.
Bye.
Thank you.
Bye.
Okay. Thanks, everybody. I'm not gonna call on all the committee chairs and officers. Is there a committee chair, though, that wants to give a report tonight?
I'd be happy to.
Okay,
Just two quick things. The first one, I'm going to do a little plug. We have done a redesign on our t-shirts, and we do have them for purchase at our cost, $16. If your old t-shirt is getting ratty, please reach out to myself or Simon or Mike. So that's the front. And that's the back.
Yeah,
Like I said,
got it.
we're only getting rid of them for $16 per, and we've got plenty of sizes available. The second thing I wanted to bring up is we've really found this year, and it kind of goes back to a comment Bobby made earlier with the current administration in Washington. We have found that these rallies that are happening seemingly at least once or twice per month have really been a wonderful opportunity for us to continue to expand our membership. Traditionally we've done the Saturday Farmers Market, where we get there and set up, and over the course of 4 hours, we try and talk to as many people as possible while they're buying produce, which is their primary purpose for going to the farmers market. And we usually maybe get 4, 5, 6 people signed up. So for example, this No Kings rally, that was on the 14th, we were there for 3 hours and we signed up, I think it was over 60 people. So, we're really kind of grabbing onto the opportunity to talk to more people. And when I say tabling, we're not just tabling. We've actually had people with their t-shirt and a clipboard and our flyers walking around and actually canvassing in the crowd. So it's been a very positive experience for us. I just ask that if you're interested and willing, we'd love to have you come and join us. We'll certainly in our newsletter and in any email blast let you know when we're doing this type of tabling activity. But it's a lot of fun and you meet a lot of really good people. So that's what I've got from communications and outreach.
thank you.
Thank you.
Yeah. Oh, Simon wants to make a quick comment.
I just want to make a quick comment that we also, since we have got a lot of interest from the university in the past several months, and we have people from the university come to the rallies as well and
Yes.
table and walk around with us. That also helps to draw in more students,
Yeah.
OSU students. We've had a lot of
Wonderful.
success with like Luke going out there. He walks around,
Yeah.
he recognizes people, he talks to other university students. It's really helped expand outward our younger
That's
sort of
great.
membership.
Yeah, that's what we need.
Yeah.
Fresh
And,
blood, future.
yes,
that
the
need it.
future. Well, it's their, in a way, we're working for their lives.
Yeah.
Okay, then, are there any officers who want to make a report? Secretary, Treasurer, or Vice Chair Huntington, go for it.
The rallies appear to be coming along twice a month. The next one that's likely to come along is either July 17th or 19th. July 17th is the 5-year anniversary of John Lewis's death. He was a civil rights champion in the Congress. And problem is, July 17th is a Wednesday. So we're hoping that they'll change it to the 19th, which would be a Saturday, but we'll try to get the word out if and when that happens, and we'll be in Corvallis.
Okay, great. Thank you.
Mark,
Yes,
I know I'm not a chairperson of the
feel free.
committee, but the legislative committee, I did just want to make sure everybody knows that SB 951 was passed and signed by the governor. The big victory, that was the Senate bill that it closes some of the loopholes in the corporate practice of medicine doctrine. So big win.
Yes.
Yep. So
Yeah, that-
everybody knew that. Is the firms against the rules, yeah.
Yeah, a major victory, of course. Yeah. Okay.
Mark, I
Um,
did, Kathy is waving her hand there, so she must have some
okay.
sort of financial
Kathy, go
news
ahead.
for us.
This is just a quick invitation to participate. The next thing the Finance Committee will be working on is a fall fundraising letter. And we're going to do a rewrite because it's really been more of an update at least the last couple of years. So if you have any thoughts where you've ever wished we would say or do something different in the fundraising letters, send me an email.
Okay. And the Finance Committee could really use another person or two. Most of our committees have, 8, 9, 10 members, and Finance has 3. And don't be scared. You don't have to be a financial expert. We already have 3 of those. We need some people who can come and brainstorm and think and be creative. So yes, please consider joining the Finance Committee, but at least giving ideas for the fundraising letter. Okay. Shelley, it's time for our 2 elections. Shelley, would you bring on the slate? We have a couple of officers to elect tonight.
Okay, we have 2 officers to elect tonight. One is our chairperson. Mark has agreed to stand for that for another 2 terms. And so
Years.
nobody else showed any interest in taking that on. So the nominating committee agrees that Mark would be a great choice to stay in that position. So that's the first election.
Okay.
And so why don't we do that before we go on to the next?
Move that we elect Mark to that position.
And second.
Okay, moved by Carol, seconded by Mike. All those in favor?
I
And in 2 years, I'm going to be calling on some of you to swap places with me. But yeah, I'm loving this, so I'm fine. Thank you, Shelley. And any against, any opposed? Any nominations? Okay, we'll move on.
Okay, and the second position up for election is the secretary. And after a long and arduous search, that it is me. I know, a deaf person. So anyway, I am the nominee for the secretary for the next 2 years. And if anyone else would like to be nominated or nominate themselves, please let us know.
Is there anyone from the floor who wants to go for secretary?
Nope.
Nope. It's a tough sell, secretary. Secretary and treasurer are a tough sell. can I have a motion then?
I move that Shelley be our secretary.
It's moved by Carol
Second.
and seconded by Linda. Okay, all those in favor, say aye.
Right.
Aye.
Any opposed? All right. We have one more. Yes, and thank you, Shelley.
Thank you, Shelley.
It feels a little odd, you know, she searched and searched and searched for a candidate and failing to find one, she had to take the job herself.
Gotta get an OSU student to take it over next time.
Yes, next time. And we have an OSU student interested in our board, so, and maybe we should actually have change our bylaws so there's always an OSU student, but anyway. So then we have some at-large members to vote on. And only board members vote for at-large board members. So, and I have a couple of people who've called in already on this, but Shelley, go ahead and tell us who it is and.
Carol Gold has decided to step away from the board for now, and Sandy, who will be leaving the secretary position, wanted to remain on the board at large. So we nominated Sandy for the at-large position, coming vacant with Carol taking a vacation.
And at the same time, we need to vote for Linda and Marisa Bell.
And yeah, Linda and Marisa Bell said they were eager and willing to remain in their at-large position. So it was just the one position that was coming open.
All right, so those are our three. Can I get a motion?
I so move.
Thank you, Bobby. Is there a second?
Second.
Okay, and Alex seconds. Any nominations from the floor? Okay, all those in favor say aye.
Aye.
Any opposed? All right, we are done with the elections.